So thank you very much. Thank you for the nice invitation. My talk will be just to cover the intersection of diabetes, atherosclerosis, and inflammation. So here are my disclosures. So just a reminder that when you look at the pathogeny of diabetic complications with the macrovascular on the right and the microvascular on the left, inflammation can play at different steps of the inflammatory process. Most clinical studies have tried to target inflammation within plaques, but you could also try to target inflammation being produced by excess fat or intermediate inflammatory markers being produced by the liver. So as a first step, I try to analyze my own patients to see how they distinguish themselves based on inflammatory markers. And I use the CRP level above or below 3 milligram per deciliter, which is a recognized threshold. Other clinical studies have used a lower marker of 2 milligrams, such as in the CANTOS trial. So 20% of patients recently seen with CRP being assayed are in the upper range. So I will call them inflammation patients. They are significantly slightly older and they are more male subjects. There are definitely more obese. This is a type 2 population, so most of them are obese anyway, but having inflammation is associated with a 3 units increase in BMI, 7 centimeters increase in waistline, and a 3% increase in fat mass, which translates into 5 kilograms. And almost all of them have a metabolic syndrome. They also have more insulin resistance, more fasting insulin, less beta cell function, and poor metabolic control, as assessed by HbA1c. So the stage is set for those patients to likely have more complications. As a control that they have more inflammation, they also have more uric acid, but that could be associated with obesity. But definitely they have more white cells of the neutrophil class, which is a reliable marker. I just found that they have different blood group distribution, so I haven't time to discuss that. But interestingly, they have more B group and less O group blood groups. They also have a much more atherogenic lipid profile, irrespective of whatever you look at. Everything is worse in those patients with inflammation except for lipoprotein little a. So they have more non-HDL, ApoB, LDL, less HDL, more atherogenic dyslipidemia, more remnant, and smaller LDL particles. Looking at their complications, if I start from the macrovascular spectrum, they have definitely more macrovascular complications, both retinopathy and neuropathy. This is highly significant. If I look at mixed macrovascular complications, they have definitely more diabetic foot and erectile dysfunction in men. Oddly enough, I didn't find any significant increase in coronary artery disease or cerebrovascular disease or peripheral artery disease, but talking about the heart, their heart failure prevalence was doubled, which I didn't realize before I did the analysis, and they had more than double prevalence of atrial fibrillation, which is a comorbidity of heart failure and vice versa. So that's how they look, my patients. So what could we do as far as inflammatory intervention have been published so far? So there are a lot of cascade, and I'm using this Italian paper of 2024, which is a very nice summary of what can be done. We can start from the pro-inflammatory cascade from the left to the right, starting with the inflammasome and microtubules down to activation of pro-inflammatory cytokines such as interleukin-1 beta and interleukin-18, and then look at the down activation of interleukin-6, which itself will activate inflammatory proteins in the liver, such as CRP, which is a recognized marker of inflammation, but that's not the only protein that will be activated by the liver. So all these could be targeted by various interventions. And this cartoon shows you what has been investigated so far. From left to the right, colchicine has been used as a polymerization of microtubules inhibitor. Then you have antibodies targeting either interleukin-1 beta or its receptor. And then again, you have monoclonal antibodies targeting interleukin-6 or its receptor. And then at the end spectrum, you can even target white blood cells using methotrexate or tried to generate regulatory T cells using low-dose interleukin-2. And my last slide will be the summary of clinical trials having been published so far, starting from top to bottom alongside a cascade. So the first drug, which is a very cheap drug, colchicine, is a microtubule polymerization inhibitor. And there have been many outcome trials. The three major ones that I will show you is the COLCOT trial in patients with recent acute coronary syndrome, showing a marked reduction of 23% in MACE, and that was significant. Then the low-dose colchicine 2 trial called LODOCO2, with a very large cohort of more than 5,000 patients with coronary artery disease, show an even larger reduction in MACE of 31%. Again, it was highly significant. And because my topic is on diabetes, the subgroup with diabetes, which was sizable in that study, show a very good benefit as well. So diabetic patients seems to benefit as much as non-diabetic from those anti-inflammatory intervention upstream of the cascade. Then you all know the next step is the monoclonal antibody against interleukin-1 beta called canakinumab in the CANTOS trial, which was published a few years ago in the New England Journal of Medicine. A large cohort of patients with previous MI and elevated CRP above 2, and there was a 15% risk reduction with that rather expensive monoclonal antibody, but it was another proof of concept that you could target a step below the initial step of the pro-inflammatory cascade. Then there was a mechanistic trial showing a decrease in an intermediary marker, which is CRP itself, with anakinra, which was targeting the interleukin-1 receptor. Then downstream, targeting the interleukin-6 receptor or its direct targeting. There was the tocilizumab trial with a small cohort of STEMI patients showing a decrease in myocardial tissue loss using the anti-interleukin-6 receptors. Then there was another mechanistic trial using a monoclonal antibody directly targeting interleukin-6 that showed significant reduction in CRP. Then there were two negative trials with methotrexate targeting T lymphocytes. The third trials with a very large cohort of CAD patients in which the MACE was not decreased at more than 2 years. And then a small numbered trial called TETIS, STEMI patients, and against no difference in infarct size. So the last step of the pro-inflammatory cascade was rather disappointing in this trial. I have not mentioned that, but in the CANTOS trial, the diabetic subgroup, which was also sizable at inclusion at baseline, showed a large benefit as non-diabetic patients. So this is what I found. I'm not